I previously ranked Tysabri as one of the most effective disease-modifying therapies in multiple sclerosis by looking at different head-to-head trials. But unfortunately, it comes with a risk of one rare but very serious side effect. Of course, that's PML, the rare brain infection caused by the JC virus. But how rare is PML? What is the risk? Well, it depends. It depends on how long you take the drug, your JC virus antibody status, the index level of that virus, your age, maybe even your weight, whether you've taken previous immunosuppressants. And I'm going to review the exact risk for different scenarios in this video. And we're going to also talk about a potential way to decrease your risk of PML, which is to take the drug less often, known as extended interval dosing. Remember what Mark Twain said, supposing is good, but finding out is better. We'll start with a brief review of what PML is. This stands for progressive multifocal leukoencephalopathy. Progressive because it's typically a slowly progressive illness over months. It can cause neurological symptoms such as weakness, numbness, vision changes, or cognitive or personality changes. It's often multifocal in different areas of the brain. I have an MRI scan showing just a single lesion, but it can actually affect different areas of the brain simultaneously, and it's a leukoencephalopathy, meaning that it affects the white matter. It has a characteristic appearance on MRI where it tends to fill up the gyri. In MS, you can get juxtacortical lesions right next to the cortex, but they tend not to be so confluent and contiguous. In other forms of PML caused by other forms of immunosuppression, such as AIDS or organ transplants or people getting high-dose immunosuppressants, often the lesions do not enhance. They do not take up the gadolinium contrast dye, which is often true in people with MS getting PML, but sometimes, particularly if the drug Tysabri is stopped, the lesions can enhance or take up the contrast dye. I personally have never had a single patient with MS taking Tysabri get PML. I had one patient with AIDS get PML. He had a lesion in the brainstem. PML is caused by a virus called the John Cunningham virus, or JCV, which is very common, and we can test for prior infection with a blood test called the JC virus antibody. And about 50% of the population has this, so they have been infected, but it causes no symptoms. The immune system simply shuts it down and controls it. We think the prevalence increases somewhat with age because people acquire the virus at some point during their lifetime. And note that this test is commonly incorrectly ordered, and some doctors will erroneously order JC virus PCR, which is almost always negative and is the wrong test. And I've heard of instances of someone getting PML when they thought they were JC virus antibody negative, but really they've never even had the test properly done. We don't know how people get the JC virus. It's been found in contaminated water. It's been found sometimes in the urine of pregnant women. We don't even know if it's transmitted from human to human. Now, some people do actually recover well from PML. There are some treatments of PML, such as doing plasmapheresis to filter out the drug Tysabri and allow the immune system to come back and attack. Some people have attempted the use of the drug mirtazapine, which is an antidepressant which blocks serotonin, because we know the virus uses serotonin receptors to enter oligodendrocytes, but there really aren't a lot of proven treatments. Sometimes steroids are used to calm down inflammation in the brain, and the mortality rate is relatively high, about 25% in people with multiple sclerosis, higher with other diseases such as AIDS. Some people do recover and do well, but many with the disease are left with significant disabilities even if they survive. So now let's move into the statistics. And before we go further, please talk to your own provider for personalized advice. My name is Brandon Bieber. I make videos about MS every Wednesday. So this is from the manufacturer itself, Biogen, and they report what is widely regarded as true, that if you test negative for the JC virus antibody, in other words, if you don't have the JC virus, your risk is very low, estimated to be approximately 1 in 10,000. And they say this is true regardless of how long you take the medication and whether or not you've previously taken immunosuppressants and other factors like your weight and your sex and your age. But this is probably not exactly true. This is data from UpToDate, and they break it down based on whether or not you've had a prior immunosuppressant and how long you take the drug. The idea with immunosuppressants is that, one, they reduce the accuracy of antibody testing, and also, of course, they make you more susceptible to infections in general. And it's been reported that the index value, or the level of antibodies, is not very meaningful for people who have taken prior immunosuppressants. Now, not every disease-modifying therapy is an immunosuppressant. Glutathione acetate and beta interferons don't weaken the immune system, but for example, B-cell depleters, rituximab, Ocrevus, and Kesimpta would be immunosuppressants. And it seems to have some effect. For instance, for people who are JC virus antibody negative but have not taken prior immunosuppressants and take the drug less than 2 years, less than 24 months, the risk is only approximately 0.02 over 10,000, or 1 in 50,000 risk. However, if they take it for more than 2 years, it's 0.2 per thousand, or 1 in 5,000 risk. Well, that's greater than 1 in 10,000, if you ask me. What about people who have previously taken immunosuppressants for less than 24 months? The risk is approximately 0.06 per thousand, or around 1 in 15,000, which is very low. But for greater than 24 months, it could be as much as 0.9 per thousand, or close to 1 in 1,000. That's much higher than 1 in 10,000. Now, you notice these are all approximate because there are relatively few people who get PML, and so there's a lot of random variation in these statistics. And of course, not every single case of PML is reported, and of course, not every JC virus antibody test is accurately reported. But the point is, 1 in 10,000 for people who are JC virus antibody negative is a good estimate, but it could be higher than that, particularly for people who have taken prior immunosuppressants, who have taken the drug for a very long time, but the risk is, generally speaking, fairly low. So what if you're JC virus antibody positive? Of course, the risk is higher, and hey, I'll say straight out, you may want to consider an alternate disease-modifying therapy, simply because we have other disease-modifying therapies that are high in efficacy other than Tysabri. That being said, if you don't take an immunosuppressant, or if you haven't taken an immunosuppressant previously, and you have a low JC virus antibody index, again, this is kind of like a titer, the level of the antibody, the risk can still be quite low. So this chart is people who are JC virus antibody positive. They have not taken prior immunosuppressants, and you can see on top, you see the JC virus antibody index ranging from less than 0.6, which is very low, to greater than 1.7, which is high, and the number of infusions, 12, 24, 36, corresponding to 1 year of treatment, 2 years of treatment, 3 years of treatment, etc. Now, for people taking this drug who have a JC virus antibody index that's less than 0.6, up to 4 years, no one got PML in this particular study, so the risk is extremely low. However, beyond 5 years, the risk was 0.3 per thousand, or roughly 1 in 3,000. So low, but it could happen, but still a very low risk. So you could say the drug is quite safe in those individuals. No prior immunosuppressants, JC virus antibody index less than 0.6. However, if you look at the right side of the chart, people with a higher JC virus antibody index who have taken it for 6 years, the risk is 29.7 per thousand, or roughly 1 in 35, which is quite a high risk for this serious of a side effect. And of course, you can look at how long you think you would take this drug and your JC virus antibody level, and think about whether or not you're comfortable with your individual risk. Now, if you've previously taken immunosuppressants, the JC virus antibody index turns out to be meaningless. In other words, the exact number doesn't really matter. It doesn't correlate really with risk of PML. So for people who've taken prior immunosuppressants, you're either positive for JC virus antibody or negative. There is no in between. So this chart looks at people who are JC virus antibody index and have taken prior immunosuppressant drugs prior to starting Tysabri and the risk of PML. So on the left-hand column, you're looking at index less than or equal to 0.45, which is essentially negative. The lab we use uses a cutoff of 0.4. I'm not sure why it says 0.45, but it's probably a meaningless difference. These are essentially people who are negative for the JC virus antibody, and you can see For these people, the risk remains low, even though they've previously taken immunosuppressants. It's 0 for the first 4 years, probably not actually 0, but just no reported cases in this sample, and 0.3 per 1,000, or roughly 1 in 3,000 risk, coincidentally the same as the prior chart. But the point is the risk is relatively low even with long-term use. But if you're positive, regardless of the index, anything over 0.45, and I would say over 0.4, the risk is fairly high if you take the drug for a long time. Again, you want to consider an alternate disease-modifying therapy if you're in this situation JC virus antibody positive and you've previously taken an immunosuppressant medication, regardless of the JC virus antibody index. Now, interestingly, there are a few other risk factors, and one of them seems to be where you live. According to this study, the risk is higher of getting PML in Europe compared to the United States. This is looking at JC virus antibody positive individuals who have not taken prior immunosuppressants, and you can see in Europe over a 6-year period the risk was 30.1 per 1,000, but in the United States it was only 12.1 per 1,000, a highly statistically significant difference. No one knows why this difference occurs, but one hypothesis is difference in body weight, that Americans are heavier and have a higher blood volume and are hence effectively exposed to a lower dose of the drug, but no one knows for sure. Another thing I should mention is you might think the risk of PML goes up and up forever the longer you take it, but that seems to not be the case. After 4 years, the risk definitely goes up, but then seems to plateau. This is looking at the risk of PML for people who are JC virus antibody positive with or without prior immunosuppressants, and you can see the risk goes up after 4 years, but then plateaus and remains at a stable level. Now, this chart is only up to 8 years. We know Tysabri was approved in 2005, so some people have taken it up to 17 years or even longer if they were in the clinical trials, but there just aren't that many people who have taken it for a very long time, so we have limited data beyond 8 years, but at least preliminarily, the risk does not keep going up forever. It seems to plateau after 4 years. So what can you do to reduce your risk of PML? Well, you could not take Tysabri, or if you're on Tysabri and you test JC virus antibody positive, you could change to a different drug. But what if you want to continue? What if you think the benefits outweigh the risk? Well, one thing you could do is take the drug less often. Instead of taking the recommended dosing regimen of once every 28 days or 4 weeks, you could do it less often, like once every 6 weeks or even once every 8 weeks some people have done. Now, this isn't the official recommendation from Biogen or from the FDA, but people have done this. Maybe it's more convenient. People didn't want to go to the infusion center. Maybe they had logistical difficulties or insurance difficulties, and so some people have taken it less often. This is an observational study looking at different risk factors for PML, and they found people doing extended interval dosing, taking it less often than every 4 weeks, had a hazard ratio of risk of PML of 0.06, meaning a 94% decreased risk. And you can see the same thing in graphical form. Now, this is not a randomized trial, just an observational study, but with such a huge effect size, we can say confidently this definitely reduces the risk of PML. But is it as effective? Well, it depends who you ask. We'll take a look at a few different studies. This is an observational study from 14 Italian centers comparing standard interval dosing every 4 weeks and extended interval dosing, and they considered this to be anything over 5 weeks. So they gave you 1 week of leeway and it would still be considered standard dosing. And they looked at the annualized relapses, the number of relapses per patient per year, and the standard group actually did worse with 0.0 relapses per year versus roughly 0.04 in the extended interval dosing, although it was not statistically significantly different, and this is a very low number of relapses, approximately 1 per 20 years. However, we recently saw in The Lancet a randomized controlled trial comparing standard dosing every 4 weeks versus every 6 weeks, and we saw a different result. Here, there were more lesions in people getting extended interval dosing. They had an average of 0.2 new T2 lesions versus 0.05 new 2T lesions. Now, this is a very small number of new MRI lesions, but it was a 4-fold difference, although there were no statistically significant differences in disability progression, which is, of course, more important than findings on the MRI. We could also look at the MS Paths database, which is of 7 United United States cities looking at MRIs of people with multiple sclerosis, and this study was through July 2020. And there was a non-statistically significant trend toward more new T2 or more enlarging T2 lesions in people with extended interval dosing. You can see the confidence intervals passed through 1, so it wasn't so clear. By the way, in the same study, both Tysabri and extended interval dosing Tysabri blew away platform disease-modifying therapies such as Copaxone or beta-interferon. Of course, the superiority of Tysabri over these medications is very well known. They also looked at brain volume, and again, there was a non-statistically significant trend toward more atrophy in people getting extended interval dosing. Once again, you can see people getting it more frequently had less brain atrophy, but the confidence intervals passed through 1, so it wasn't so clear. But maybe something is going on here where the every 4-week dose is a little bit better. It's hard to say for sure. Furthermore, even if we can't objectively prove the brain is being damaged from taking the drug less often, some people just subjectively feel worse if they haven't had Tysabri in a while. These are so-called wearing off symptoms that are experienced between dosing, particularly close to the next dose, and they could occur with the every 4-week dose or the every 6-week dose, but presumably they could last longer if you're taking the drug less often. And these are things like fatigue, mood changes, or even walking difficulties, spasms, and pain. And some people notice these and they can be quite significant and debilitating. Now let's move back to a few miscellaneous topics. As I mentioned before, having a low body weight is a risk factor for PML. Here it's better to be heavier. They found that the risk for people who weigh less than 60 kilograms is 8.6-fold higher than for those with a weight greater than 75 kilograms. And that's a relatively small difference in weight, but a huge difference in risk. And it may have to do with the fact that bigger people are still getting the same dose. It's a set dose of 300 milligrams, so you're effectively getting less of the drug if you're heavier. We also know that older people are more likely to get PML, although most comorbidities, other medical conditions, aren't strongly associated with PML, with the exception of conditions causing an immunosuppressed state. Now, for people who wish to continue Tysabri despite having a higher risk of PML, it may be reasonable to do frequent screening MRI scans to look for PML, because sometimes early on it can be asymptomatic and it may be possible to catch it early before it causes significant brain injury. Though in my opinion, it's all about prevention, and it may be better to just change medications to reduce the risk. And to go back to the body weight issue one more time, this is a graph of people with and without PML and their BMI. So the red dots are people with PML and the blue diamonds are people without PML. And you can see most of the cases of PML are clustered in people with a lower body weight. Now this makes sense in terms of physiologic studies. These two graphs are looking at the occupancy of receptors on lymphocytes of the drug Tysabri. So Tysabri binds a receptor on lymphocytes and prevents them from entering the central nervous system. And before the infusion, everyone has relatively high occupancy because they just got the drug, regardless of their body mass index. However, before the infusion, before the next infusion, after the drug levels have gone down, you can see receptor occupancy dwindles, especially in people with a higher body mass index, because they're effectively receiving less of the drug. So for people with a lower body weight, perhaps it makes sense to get the drug less often to reduce the risk of PML if someone is at higher risk. The last issue I want to talk about is the idea of stopping Tysabri. And generally speaking, if someone tests positive for the JC virus antibody, and that is their reason for stopping the drug, I would often recommend a screening MRI at that point, because sometimes people could have asymptomatic PML. I personally have never seen this, but it is possible. And particularly if someone plans to start a new immunosuppressant drug, there is a small risk of carryover PML. In other other words, PML that is diagnosed when someone is on a new drug but was actually caused by Tysabri. Now, in the past, doctors used to recommend a washout, recommending their patients stop Tysabri and not start a new drug right away to allow the drug to wash out and the effects to wear off. But unfortunately, there's a risk of rebound. The idea is that Tysabri blocks the lymphocytes from entering the nervous system, but if you take away the drug, they can rush right in, and sometimes around 4 to 6 months after stopping the drug, people can get much, much worse and have a severe relapse. So generally, that's no longer recommended, and it's recommended to start a new drug shortly after stopping Tysabri, such as 1 month after the last dose. Now, which drug should you stop? There are different options, but there's some evidence that B-cell depleters such as rituximab, Ocrevus, and Kesimpta may be very effective at blocking the rebound and are probably more effective at least than platform drugs such as glatiramer acetate or beta interferon, which are not very effective at stopping rebound. Now, in general, the risk of rebound is much, much greater than the risk of PML. Again, I've never seen a case of Tysabri-related PML in my whole career, but I've unfortunately seen rebound many times. People stop taking the medication, people have insurance issues, people move, people get pregnant, things happen, and so unfortunately rebound does happen. And generally speaking, I would advise someone to continue taking Tysabri even if they are JC virus antibody positive until they have a plan to get the new drug, because again, generally speaking, the risk of rebound is greater than the risk of PML, and testing JC virus antibody positive is not an emergency, it's more of a long-term risk factor for the development of PML. But of course, talk to your own provider for any specific questions. If you have any comments or questions, I'm happy to field them in the comments below, and let me know if you have suggestions for future videos.